The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. Today is Tuesday. The date is January the 14th, 2025. We're beginning a new year and a new series of episodes of TMD Demystified. I am Tony Urbanek. Today's topic will delve into fact-checking for TMD/TMJ. As you, I'm certainly are aware, that certainly is a buzzword now. I don't think it even was in the dictionary just a few years ago, but everything now is being fact-checked. Fact-checking is not necessarily equivalent with good practices. It is not equivalent with academic research. And they stand alone as far as the quality of determining whether a set of facts has value or proposed facts has value. But today, it is kind of the quick and dirty euphemism for describing someone with or without credentials who goes in and takes a topic and reviews it or tries to uncover facts about it, hopefully with their own personal bias. Now, TMD, for those interested in watching, is a very controversial topic and has been my entire career in dentistry. And by the way, I am aware now that there are an increasing number of non-dental people, basically patients with TMD, who are beginning to watch this series of episodes on this podcast, TMD Demystified. And to you specifically, I say welcome. I try to keep my descriptions very simple without a lot of verbosity and technical words, but I can't help it because these episodes are directed to professionals, primarily dentists, who are interested in learning more or treating TMD. However, a more simplified description of each and every one of these topics can be seen on our YouTube programs and on our website, on a blog that I write on a weekly basis that covers these same topics. So there's another resource for you to review if you are not a doctor. It may be more meaningful to you. So my last blog, which was written just 2 days ago, was entitled Fact-Checking TMD TMJ, Part 1. And as my usual custom, I then do the following episode of TMD Demystified directed to doctors a few days later. So today we're going to kind of pick apart only one of the things that needs to be discussed and fact-checked regarding TMD, which is extremely common. To give you a little background, if this is your first episode watching, I am an oral and maxillofacial surgeon who did surgery on these temporomandibular joints over a period of 36 years, over 2,000 cases of various degrees of surgery, but I've done every single kind of temporomandibular joint surgery, some of them hundreds of times. But 12 years ago, I decided that surgery was not going to be the long-term solution because in my own practice, which was extremely busy doing temporomandibular joint surgery, along with multiple other kinds of maxillofacial reconstructive procedures, I found that 30 to 40% of my TMJ patients were back within a year or two with the same symptoms. And after reviewing my entire, at that point, 36-year career doing temporomandibular joint surgery, I decided that I was going to not do any more temporomandibular joint surgery and go on a research project of my own to see if I could figure out why no one really knew what TMD was all about. And that story is well described in other places. I'm not going to go through it now. But with that in mind, 12 years ago, I did the research and I actually uncovered the actual pathophysiologic mechanism. What I discovered was the actual pathophysiologic mechanism which creates all of the symptoms. And the common denominator is inflammation within the joint. Inflammation creates all of the symptoms. A lot of this is common sense, and that's what surprised me and surprises me to this day, the amount of common sense which is not directed toward this problem. In any case, you can kind of look at it yourself. You don't have to be a doctor, kind of doctor or not. Everyone knows that if you use a non-steroidal pain medication for, in this particular case, temporomandibular joint symptoms, it's very effective, but only for a short period of time. It kind of runs out of steam. The patients know that, the doctors know that, the physicians know that. Non-steroidal pain medication, anti-inflammatories actually, non-steroidal anti-inflammatories work really well. They are anti-inflammatory. So if they work in the short term very well, would it not stand to reason to be looking for something that decreased inflammation in the long term, which had not been done? So I'm not going to go into the history of the discovery and how that came to be, and how we did substantial technical work on it, studies on it, based on 3,000 successfully treated patients. Today, we're going to facts check some of these very unusual concepts that have been used and abused and promoted for the temporomandibular joint patient, which have no reason behind them. They are basically nonsense. And the first one I'd like to talk about is the night guard, which has been the standard operating treatment, standard operating procedure, standard operating solution for what everyone calls TMJ for the past at least 70 years. At least 70 years. So a night guard, here's how it shakes out. 50% of the dentists in the United States of America, if they think or have been told a patient has TMD, they will prescribe a night guard as the solution. And then the other 49.9% of the dentists who are faced with a patient who may have or actually have TMD don't want anything to do with that patient because they know that nothing works. So that's 99.9% of the dentists in the United States of America either treat it with a night guard or don't treat it at all because they know that nothing works. That's the consensus in the dental industry and the dental profession in 2025. And that has been the consensus since I started my dental career in 1973. So, but the patients and the doctors, and especially the doctors, especially the 50% who continue to recommend a night guard for the treatment of TMD, need to have the facts brought to their attention. Now, this is a night guard. This is a night guard that is made by a company, sent to me by a company that wanted me to use their night guard. And so I just kept it around as an example of what a night guard is. We see a lot of night guards around here. Patients, I know a patient has been through the night guard routine when they come in with a brown paper bag and they shake the bag as they enter the consultation room. And I know what's going to happen next. They're going to want to show me all of their night guards that they have made. 2 night guards, 4 night guards, 6 night guards that have been made by various dentists over a period of time for the treatment of their symptoms that everyone now calls TMJ. TMJ is the name of the joint, not the name of the problem. But a night guard, what is a night guard? A night guard is nothing more than an acrylic or resin device. The only ones I've seen have been resin made or acrylic made that fit over the surfaces of the teeth, either the upper arch, this is an upper arch, or a lower arch of the mouth, of the teeth, and given to the patient to use for their symptoms of TMD. Now, I entered the dental profession as a dental student, freshman dental student, 1969. I entered dental school as a freshman. By 1972, I had a lot of the dental training under my wing already. And having a lot already accomplished, I was invited to the oral medicine clinic, which was a big deal at my university, Indiana University. And I was very interested to see what the dental profession called dental medicine. Well, not to belabor it, but basically it was a series of patients who had very specific and sometimes nondescript pains in and around the face and oral cavity that had nothing to do with dental pain, nothing to do with periodontal disease or dental decay. And it was up to the oral medicine doctors to try to figure out how to diagnose and treat these things. I can vividly recall listening to a patient being presented by one of my colleagues who had the usual headaches, earaches, jaw pain, shoulder pain. And there was a small number of dental students standing around this patient with a professor. And after the diagnosis and the history was taken, the diagnosis was made. The diagnosis was made as TMJ at the time. The doctor recommended a night guard for the patient. Of course, I didn't even have my dental degree at the time. So I basically was just an observer, but I always had questions. And patient was prescribed a night guard and set up to have that delivered at some point in time. After he finished his presentation, I asked this professor, how does this night guard work? Like, how is this piece of acrylic going to cause all of the headaches to go away, or the shoulder pain to go away, or the ear pain to go away? And again, as I can vividly remember, all I received from this professor was a bunch of word salad that didn't make any sense to me at all. He definitely couldn't answer the question. And this was a professor. He couldn't answer how a night guard physiologically, how it worked, but he did prescribe that. So flash ahead approximately 50 years, and that same thing is going on. There is no difference. Dental schools continue to teach dental students that a night guard is the superior treatment for TMD, but no one can explain why they're prescribing it and how that's supposed to work. And the fact is, it doesn't, because patients in my experience and the experience of many other doctors, have been prescribed multiple kinds and portions of night guards, which have not proven to be effective at all. So a night guard does have a value. There's some value to a night guard. The thought process behind this is very simple. The doctors prescribe a night guard because bruxism, or clenching and grinding, is known to be one of the primary causes of TMD. Bruxism itself, clenching and or grinding, day and or night, clenching is straight up and down, grinding is back and forth, and they both are equivalent in causing, known to be causing, the symptoms or some of the symptoms of TMD. However, we don't even understand the mechanism of bruxing. We know that patients clench and grind their teeth, and the only thing we know about bruxing, it is related to stress and anxiety. We do not understand how stress and anxiety converts within the central nervous system to create bruxing, clenching or grinding. Now, there are many theories. I admit there are many theories, and they are theoretical. And we do know it is a nervous system problem, and we can surmise that the nervous system problem is centered in and around the brain stem, where the basic functions of the autonomic nervous system are located, because a bruxing action is not a voluntary thing, it's an involuntary thing. And the involuntary motions and services within the body are served by the autonomic nervous system, which is generally focused within the brain stem. Your breathing mechanism, your heart rate, things like that, gastrointestinal function. Those are all autonomic, controlled by the autonomic nervous system rather than the voluntary nervous system. So the thought process and actual theory behind using a night guard is that somehow a piece of acrylic that covers the surfaces of the teeth is going to stop someone from bruxing. Well, that's just not true. Patients had one this week who had worn a night guard for a period of time and chewed right through it, and certainly had no decrease or diminishment of her temporomandibular joint symptoms. But this is a common occurrence. So for you doctors out there who insist on providing a night guard to your patients for bruxing, in the hopes that by decreasing bruxing, you will be treating their temporomandibular joint symptoms, night guards don't decrease bruxing. If anything, they will increase bruxing, and that's why they don't work. And someone needs to speak up about this. Someone needs to use a little common sense and fact check the fact, number one, that 50% of the dentists do that, and that it is not effective, and it's not effective at all, and that no one can explain academically or otherwise how putting a night guard will actually decrease bruxing. So that is kind of a very obvious and the first place to start about fact checking concepts and treatments and theories that go along with this problem that we call TMD, TMJ. This is a very controversial problem, controversial disease and controversial problem, I admit. And I encourage, if anyone would like to enlighten me or argue in a gentlemanly way how a night guard decreases bruxism, I would like to hear from you. I encourage you to contact me. But so far, in all of my 184 episodes of TMD Demystified, encouraging doctors to contact me if they disagree with my points of view. I have not had one single doctor argue with my line of reasoning, logic, or material that I present. Not one. And I encourage them to do it. And I encourage the listener now to do it. If you feel that you know how a night guard decreases bruxism or the mechanism by which a night guard will treat TMD symptoms, please contact me. I would like to know what you know. But there is a way to treat this by decreasing the inflammation. As I said, if the entire problem is driven by inflammation within the joint, the best way to treat the problem would obviously logically be figure out a way to decrease inflammation within the joint over a long period of time, which is what I did in my research. We figured out the easiest, best way to decrease inflammation within the joint is the same way an orthopedic surgeon would decrease inflammation within the knee if the patient declined and needed knee surgery, but declined knee surgery, or the patient needed knee injections and declined knee injections, which are only temporary themselves as far as the knee goes, but they declined treatment. The orthopedic surgeon would tell the patient to get on a set of crutches, and that set of crutches would decrease the inflammation in the knee adequately, where the knee symptoms would diminish and go away. And that same thing applies to this joint. Same thing if you have tennis elbow. Tennis elbow is inflammation of the lateral epicondyle of the elbow because of too much motion. And the proper treatment for tennis elbow is to put the arm in a sling over a period of time, which rests the joint itself and allows the inflammation to decrease. That same thing applies to the temporomandibular joint. And the easiest, the best, most successful way to rest the temporomandibular joint is to unload the joint by using a device that separates the posterior teeth long enough, according to a proper protocol with oversight by a professional, long enough so that the inflammation within the temporomandibular joint goes away and the symptoms go away. There is a huge difference between this device and this device. They're both classified as devices. This is a night guard. This doesn't work. No one can describe how it is effective in either decreasing the symptoms or decreasing bruxism, but it is used by 50% of the dentists in the country for temporomandibular joint symptoms. This device is a very simple device that separates the posterior teeth according to a proper protocol with oversight by a proper professional. In so doing, the inflammation within the joint goes away and all the symptoms, including painful symptoms and non-painful symptoms, which are tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, like you've been swimming and can't clear your ear, and vertigo, dizziness. Those are the non-painful symptoms of TMD. They go away also through a separate mechanism, other than the painful symptoms, which is a mechanism associated with the autonomic nervous system. So the paradigm has been changed. There is a change in paradigm. The change in paradigm is to decrease inflammation within the joint. Bruxing on a piece of acrylic between the teeth does not do that. Never will. I think that the internet has brought a big change to our culture, our society, our politics, our medicine for sure, and a whole lot of other features in our society, in our country, and on the planet. Obviously, it is debatable whether you think some of these symptoms are good or some of these differences and changes with the internet are good or bad. I think all of that is somewhat debatable. I think the sword has two edges, for sure. It cuts both ways. And this applies to what we're doing here today. I think that because of the access to the internet more people have the availability to listen and read and get questions answered. The question is whether or not, first of all, the question you ask is a question which will lead you to a solution. And the second is, does your question, does it get answered correctly? Is it based on fact rather than fiction or nonsense or word salad? So I made my point. I'm not going to belabor it anymore. I think, I hope that there are at least a few of the doctors out there, of the dentists out there, who, for whatever their reason is, feel it's the right thing to do, is to just prescribe a night guard for a patient and hope they don't come back because they know it's not going to work. I've had so many dentists tell me they don't want to treat TMD because they don't want to get married to the patient. They use that word, married to the patient. And the inference is the patient keeps coming back. No matter what the doctor does, no matter what he tries to do, it's ineffective, and the patient keeps coming back. No, it's not working. No, I have problems, until the patient finally decides to either stop going to that doctor or go to a different doctor or just give up. And we see plenty of that around here. That is the nature of the art and science of TMD in 2025. It is my mission to change that. And we just started out by a brief and very controversial discussion of the night guard. If you'd like to learn actually how to treat TMD successfully in the way I briefly outlined, your access to the information can be received at www.urbanektmj.com. You can read all about thousands of patients have been treated successfully. You can get access to our scientific, academic, statistically studied and proven paper and study that was accomplished based on 3,000 successfully treated patients. And again, I encourage any of my colleagues who would like to discuss this with me, who would like to disagree with me, be prepared to defend what you have to say academically, statistically, logically, medically, and scientifically. With that said, next week we'll choose another topic for this series that I'm going to produce on fact-checking TMD, TMJ. I'm Tony Urbanek, and I look forward to the next time we meet. I appreciate you watching.